Good evening, ladies and gentlemen. The topic of my today's lecture is the cutaneous reactions to cold and heat. This is chapter 125 of Textbook of Dermatology by Rook, and I am Professor Asher Ahmed Mashood. You can follow me on Instagram and can contact me on email and WhatsApp. The physiological reactions to cold. Everybody knows that exposure to cold cause constriction of arterioles and vein by a direct mechanism that is mediated in part by endothelial synthesis of a vasoconstrictor peptide known as the endothelin 1. So whenever there is cold or drop in temperature, there is a release of a vasoconstrictor peptide known as endothelin 1, which causes vasoconstriction of both arterioles and the veins. This cold-induced vasoconstriction causes shunting of blood to the deep venous system that allows heat to be transferred from the arteries to the vein. And in other words, the heat is preserved. Consequently, the arterial blood passing into the limb is cooler, but the venous blood returning to heart is warmer. So less heat is lost to the outside environment. So this is the physiological reaction of cold over the body. Persistent exposure of fingers to cold leads to a hunting reaction of Lewis, in which there are repeated cycles of vasodilatation following periods of vasoconstriction. So there is a limitation of the tissue regarding the vasoconstriction. So if the vasoconstriction remains for a little period of time, the tissue tends to lose oxygen, and then it would require a cycle of vasodilatation, which is called as the hunting reaction of Lewis, so that the blood flow is restored. And after some time, there is again a cycle of vasoconstriction followed by vasodilatation. This is also a physiological response. Then cold-induced vasoconstriction is actually a heat-preserving mechanism, but prolonged vasospasm may jeopardize the vitality of the skin. Cold-induced vasoconstriction causes a rise in intracapillary pressure and increased filtration of fluids into the interstitium, resulting in hemoconcentration and reduced in plasma volume. So these are the other effects if the vasoconstriction remains prolonged for a specific period of time. There is filtration of fluid into the interstitium, reducing the plasma volume and causing hemoconcentration in the blood. After discussing the physiology, let's discuss the diseases which are caused or aggravated by cold. Certain individuals suffer cold-related disorders on exposure to modest degree of cold that would be tolerated without ill effect by other normal individuals. So this statement says that like other diseases, cold-induced diseases are also prone in certain individuals, while other individuals, the cold will not cause any ill effect. Hence, the cold-induced diseases are divided into two groups: diseases of cold exposure and diseases of abnormal susceptibility to the cold. Diseases of cold exposure will be same for all the population, but diseases due to abnormal susceptibility to cold will be pronounced in those who are susceptible. So if we tabulate the diseases which are caused or aggravated by cold, the diseases of cold exposure which will be same whether the individual is more or less susceptible to cold are the frostbite and the trench foot. While the diseases which are due to abnormal cold susceptibility include the Raynaud's phenomena, the Livedo reticularis, cold Cryoglobulinemia, cold agglutinins, cold hemolysis, cold urticaria, Perniosis, Acrocyanosis, Erythrocyanosis, cold erythema, cold paniculitis, and neonatal cold injury. Frostbite. This will be the first condition we are going to discuss today. We are not discussing Raynaud's phenomena in this chapter because I've already delivered a detailed talk on Raynaud's phenomena last time. Frostbite is the tissue damage which is caused by freezing. Frostnip is a milder form of frostbite that is characterized by reversible erythema, which normalize on rewarming. So frostnip is a mild injury, causes erythema, which is reversed after the tissue is warmed. Frostbite and its precursor frostnip can lead to varying degree of tissue damage, ranging from erythema to necrosis of soft tissue, later on necrosis of muscle and the bone. Most cases of frostbite are seen in the winter sport enthusiasts and the climbers who have been stranded in exposed sites in cold weather. So, to develop a frostbite, there has to be an extreme degree of cold injury, which is possible only in skiers, the skydivers, and water sports. Then in those climbers who are climbing the snow-clad mountains. Frostbite also occur in soldiers, in homeless people, and those who work outdoor in cold climates. The risk of frostbite increases in alcohol use and in smoking. Pathology. The freeze-induced damage results largely from the formation of ice in both intracellular and the extracellular compartments. The ice crystals not only injure the cellular architecture, but also disturb the flux of electrolytes and water across the cell membranes. The degree of cryo damage, that is cold-induced damage, is also influenced by rate of thawing, that is rewarming. Slow rewarming causes formation of larger and more destructive ice crystals and development of greater degree of osmotic stress. So this shows that whenever you are managing the frostbite victims in emergency, rapid rewarming is required. Slow rewarming is absolutely contraindicated. Reflex vasoconstriction in extremities result in decrease in capillary perfusion, which is aggravated by cold-induced hyperviscosity and tendency to thrombus formation. Clinical features. The part of body that can be least protected from cold are affected. So these are the toes, fingers, ear, nose, and cheek. So it is must that a person should wear appropriate protective socks, gloves, masks, etc. in cold weather to protect himself or herself from this cold injury. In the superficial frostbite, there is involvement of skin and subcutaneous tissue with erythema, accompanied initially by pain, and then there is a sense of warmth. The affected skin becomes waxy and white due to hypoxic injury. The injury in deep frostbite extends to the subcutaneous tissue and may involve the nerves, major vessels, muscle, bones, resulting in joint immobility and paralysis. The degree of damage may take many weeks to become apparent. Classification of severity. First degree frostbite, which is the most common kind of frostbite, is because of partial skin freezing, characterized by erythema, edema, and hyperemia. There is no blister or necrosis. Desquamation develops in 5 to 10 days, leading to complete recovery. Then second degree frostbite, which is the next common, has the full thickness involvement, and the full thickness of the skin is frozen, resulting in erythema. Edema is more. Then there may be vesiculation and blistering, and a black scar is formed, which is, of course, superficial, and it is lost with the resulting ulceration that may require skin grafting. Third degree of frostbite involves the bone and requires the bone amputation. Fourth degree frostbite necessitates the major amputation and is also complicated by systemic effects. So this is the first degree of frostbite, very similar to Perniosis. Then this is the second degree, where you can appreciate the blister formation on the fingers. Then this is the fourth degree frostbite, where you can see that there is a sharp demarcation between the healthy and necrotic tissue. And this will lead to auto amputation, or you have to do a surgical amputation in this case. First degree, second degree, third and fourth degree, leading to complete necrosis. Complications and comorbidity. The extent and severity of tissue damage become apparent on rewarming. Blistering, full thickness skin necrosis, and gangrene is seen in severe cases. Then damage to nerve blood vessels leads to paresthesias, abnormal sensitivity to cold and hyperhidrosis, which may last for months to years. The prognosis of frostbite injury only become apparent over a period of weeks as the demarcation line develop between the viable and non-viable tissue. To investigate technetium-99 bone scintigraphy is helpful in evaluating the outcome of frostbite injury over the bone, indicating the level of amputation which will be required in severe cases. MRI is also beneficial, with the ability to visualize directly any vascular occlusion and simultaneously image the surrounding soft tissue. Management. First line. It's important that immediate rewarming of the tissue should be done. Debridement surgery should be delayed until the full extent of the recovery and persistent damage is clear. Rapid rewarming is done by immersion in water of temperature 37 to 39 degrees centigrade. As the water cools rapidly, it needs to be topped up to maintain the temperature and circulation around the limb. So this process is to be continued for a long period of time. As highlighted before, the rapid rewarming is shown to be more effective than slow rewarming, and the tissue can be considered completely rewarmed when it takes on the red-purple appearance and is soft and pliable to touch. So till the tissue takes the red or purple appearance and becomes soft and pliable, we have to continue this warming process. The area should be air dried and patted dry to avoid the shearing force or damage to the tissue. Other authors advocate a higher temperature rewarming for at least 30 minutes at 40 to 41 degrees centigrade, unless the tissue is soft and pliable, with continued twice daily warming. As far as the drugs, NSAIDs such as ibuprofen at 12 milligram per kg body weight twice daily in order to reduce the level of prostaglandins and thromboxanes that contribute to vasoconstriction, ischemia, and tissue damage. The NSAIDs also help alleviate the pain. Topical aloe vera gel is suggested on the basis that it should reduce the inflammatory prostaglandins. It is recommended that non-hemorrhagic blisters should be aspirated, as the blister fluid also contains prostaglandins and thromboxane. The blister roof should be kept intact and not debrided. Second line treatment. The retrospective studies has indicated the reduction in need of digital amputation if intra-arterial infusion of tissue plasminogen activator is given within 48 hours of injury. In addition to creating vasodilatation, tissue plasminogen activator also inhibit intravascular occlusion and platelet aggregation. If aspirin is combined with buflomedil, iloprost, tissue plasminogen activator, the results are much improved. So it is recommended that aspirin with iloprost should be done as the first line therapy for third degree frostbite. The third line treatment is surgical removal of gangrenous tissue, which must be delayed until there is a distinct demarcation between viable and non-viable tissue, a process that may take several weeks. Trench foot. Trench foot describes a combination of stasis, a non-freezing cold injury. Unlike the freezing cold injury of frostbite, this is a non-freezing cold injury, and a wet condition leading to numbness and skin changes on the distal legs and feet. This is most common among the homeless. Smoking and peripheral vascular disease probably contribute to the severity of tissue damage. Clinical features. Affected individuals develop numbness of the feet and distal legs, accompanied by skin changes that are caused by non-freezing cold injury. This is compounded by wet conditions and aggravated by leg dependency, immobility, and constrictive footwear, tight footwear. Affected leg and feet are cold and anesthetic. There is erythema, edema, tenderness, and in severe cases, area of superficial gangrene. On rewarming, there is worsening edema, hyperemia, and painful paresthesias. The differential diagnoses include diabetes, arterial and venous insufficiency, autoimmune diseases, inflammatory diseases like pyoderma gangrenosum, and infections. Prognosis. Initially, the ability to sweat is lost, but with time, there is hyperhidrosis, cold sensitivity, and vasomotor instability. Changes persist for months or years. Investigation required depends on the clinical presentation. Usually, there is a clear history of cold water immersion, and no further investigation is required. Management. The best approach in management is prevention. But once the condition has occurred, bed rest, elevation, and analgesics are helpful. Conservative excision of necrotic tissue may be necessary, and antibiotics should be prescribed whenever there is any infection. The third condition we are going to discuss is a very common condition we commonly encounter, and it is perniosis or the chilblains. Perniosis describes a localized inflammatory reaction lesions on the acral skin, such as digits, nose, and ear, that occur as an abnormal reaction to cold in susceptible individuals during autumn or winter climate in both cold and damp weather. There is a female predominance, 79% of the affected individuals are female. The etiological factors include the poor nutrition, anorexia nervosa, and systemic diseases, most typically SLE and hematological malignancies. There may be a genetic influence, and several family members are involved. Pathophysiology. In perniosis, there is a persistent cold-induced vasoconstriction of deep cutaneous arterioles with concomitant dilatation of small superficial vessels. There seems to be no quantitative or qualitative difference in immunoreactivity for substance P, neuropeptide Y, calcitonin gene-related peptide. In uncomplicated perniosis, the neural supply to the microvasculature is normal and suggests that the pathology involves the microvessels themselves. So it is not the cytokines, it is not the nerve fibers, but it is the microvessels themselves that are involved. In pathology, the epidermis shows hyperkeratosis, acanthosis, thickening of epidermis, and necrotic keratinocytes with spongiosis. There is edema in the papillodermis and heavy perivascular lymphohistiocytic infiltrate superficially. There is sometimes evidence of lymphocytic vasculitis. Red cell extravasation may be an additional feature. Clinical features. The lesions are red-purple, usually macules, papules, or nodules. Plaque-like chilblains also occur, as do lesions in annular morphology. Perniosis develops symmetrically on the acral skin, particularly the finger and toes, but other body extremities may also be involved that include heel, lower leg, nose, and ear. Pruritus and burning pain are both common symptoms. This is a common presentation of perniosis. You can see the erythematous and purplish papules and nodules on the acral skin. And this slide shows de-escumation of the skin along with some papular and violaceous lesions. Chilblain LE or Hutchinson's lupus. It is a form of cutaneous LE that presents like idiopathic perniosis, but the difference from the idiopathic perniosis is the lesions are persistent and tend to become ulcerated. Chilblain LE is accompanied by discoid LE and other form of cutaneous LE. Up to 20% patients of Chilblain LE develop frank SLE. The clinical variants. In papular perniosis, crops of small chilblain develop on the sides of the fingers, often on the background of acrocyanosis. Perniosis occurring on outer thigh is reported in women who are horse riding enthusiasts, which is called as the equestrian paniculitis. Chronic perniosis, especially in presence of arterial diseases, irreversibly cause fibrosis and lymphedema. Then the differential diagnosis. We can confuse perniosis with EM, especially if there is annular morphology. Then granuloma annular, peripheral vascular insufficiency, and vasculitis. Prognosis. Most patients with uncomplicated perniosis experience good disease control with treatment and prevention. Investigation is generally not required, but it is done only in resistant patients with other comorbidities. Hence, for such patients, you order full blood count, protein electrophoresis, autoimmune screening, cryoglobulins, and cold agglutinin levels. Management. First of all, prevention and then the treatment. For the prevention of chilblain, avoid cold and wet environments. Wearing warm, dry clothing during cold weather to protect hand, feet, and ear. Then vigorous exercise to keep warm and improve circulation. Keep indoor area warm and dry. Then avoid smoking and other vasoconstrictors. Topical treatment include topical nitroglycerin 0.2% or 10% tincture benzyne co-ointment. Then in case of inflammation, topical betamethasone valerate 0.1% twice daily relieve itch. Systemic treatment include oral steroid for variable period of time, non-steroidal anti-inflammatory drugs, and vasodilators like nifedipine 20 to 60 milligram 3 times daily and pentoxifylline. The next disease we are going to discuss is acrocyanosis. Acrocyanosis is persistent erythrocyanotic mottled discoloration of hands and less commonly feet and face. It may be idiopathic or secondary to a number of systemic disorders, including an underlying malignancy. Presentation is typically in adolescence with reported female preponderance. Acrocyanosis in young adults may disappear spontaneously by middle age. The etiology of acrocyanosis is long, and it can be idiopathic or secondary. The secondary acrocyanosis can be due to autoimmune conditions like connective tissue disorders, primary and secondary antiphospholipid antibody syndrome. The neoplastic conditions include benign and malignant paraproteinemias, paraneoplastic syndrome, and cryoglobulinemia secondary to neoplasm. Eating disorders include anorexia nervosa and bulimia nervosa. Orthostatic disorders include chronic orthostatic intolerance or adolescent chronic fatigue syndrome. Neurological disorders leading to acrocyanosis include brachial plexus neuropathy or chronic arsenic poisoning. Drugs include butyl nitrate and interferon alpha 2A. Metabolic diseases include fusidosis and ethyl malonic encephalopathy. Psychiatric conditions can also lead to acrocyanosis, and these conditions include severe learning difficulties, schizophrenia, and essential thrombocythemia. Pathophysiology. There is a vasospasm of peripheral arterioles aggravated by cold and dilatation of subpapillary venous plexus. Decreased acral blood flow may be further compromised by plasma hyperviscosity. Clinical features. Idiopathic acrocyanosis start in adolescence and persist into adult life. Changes may be transient after cold exposure, but usually persist during winter and even throughout the summer months. Clinically, there is painless mottled duskiness of both hands in presence of normal peripheral pulses. Similar changes are seen in the feet and the face. Trophic changes such as ulceration is usually absent. This acrocyanosis must be distinguished from Raynaud's phenomena, which occur episodically with triphasic color changes and involves just a few digits. Differential diagnosis also include Raynaud's phenomena, arterial occlusion, and venous occlusion. In investigation, if we have a confusion with Raynaud's, we must do capillaroscopy to demonstrate dilated and congested capillary loop at the base of fingernail, which are changes seen in secondary Raynaud's phenomena. Duplex vascular ultrasound is used to exclude intravascular thrombosis. Management. There is no effective medical treatment for acrocyanosis. Vasodilator therapies like nifedipine or calcium channel blockers do not appear to be beneficial. Treatment of underlying systemic disorders, the long list I have just narrated, may improve the appearance of secondary acrocyanosis. Then the next disease we are going to cover is erythrocyanosis. This is a little different from acrocyanosis. Erythrocyanosis is persistent dusky erythema occurring at sites with thick layer of subcutaneous fat, such as thigh and lower leg. So this condition, unlike other cold-induced injuries, occur particularly in those areas which are covered by thick fat layer. So it is common on buttocks and arms, and most commonly seen in girls because they have a thick fat layer and middle-aged women. It is hypothesized that the subcutaneous fat act to insulate the superficial vessels from the warmth of the underlying blood supply, thus rendering them susceptible to cold exposure. Erythrocyanosis is characterized by dusky discoloration of skin and may be accompanied by keratosis pilaris, angiokeratomas, and telangiectasias. The areas are cold to touch. Edema and fibrosis may be seen in chronic erythrocyanosis. So, in addition to the red dusky erythema, there is edema and fibrosis as well. Livedo reticularis may be considered, but livedo reticularis is in a net-like manner. Erythrocyanosis is diffuse. Spontaneous improvement can occur in adolescent patients. Investigation is not required, and management is warm clothing, exercise, weight reduction, elastic support hosiery. Vasodilators like calcium channel blockers are of limited value. Now, the next condition is very important. It is livedo reticularis. This is the mottled cyanotic discoloration of the skin with characteristic network pattern. It is accentuated by cold. This condition is created by low blood flow within the anastomotic areas of the skin. Pathophysiology. Blood supply of skin is arranged in cones, base of which is measured as 1 to 4 centimeter in diameter on the skin surface. So the base of the cone is on the skin, while the tip of the cone is below from where an artery is supplying that area of the skin. Each cone is supplied by an arteriole that passes through the dermis perpendicular to the surface. When there is blood flow through the feeding arteriole is diminished, the deoxygenated blood at the anastomotic junctions produce cyanotic network-like pattern on the skin. So this mottled branching pattern is produced at the watershed areas, which are actually the demarcation line area between the cones, adjacent cones. So the area which is the most distal part of the cone will take the hypoxic injury to the maximum and will become mottled and blue and cyanotic. Classification of livedo reticularis. The physiological livedo reticularis is cutis marmorata, which is seen in many infants. Then congenital or idiopathic livedo reticularis include cutis marmorata telangiectatica congenita, and acquired idiopathic include uncomplicated type with winter or summer ulceration and with systemic vascular involvement. Secondary livedo reticularis occur secondary to intravascular obstruction like stasis, paralysis, cardiac failure, or amantadine therapy. Several occlusive diseases causes livedo reticularis, occlusion because of emboli, oxalosis, or compressed air. Bismuth pentazocine, NSAIDs, minocycline. Then thrombocythemia, cryoglobulin, and cold agglutinins. Vessel wall disease, like arteriosclerosis or arthritis. Arthritis like polyarthritis nodosa, SLE, antiphospholipid syndrome, rheumatoid arthritis, dermatomyositis, lymphoma, and pancreatitis all result in livedo reticularis. Several infections are associated with livedo reticularis, which include tuberculosis, syphilis, hepatitis C, brucellosis, and Coxiella. Metabolic conditions include hyperparathyroidism, hypercalcemia, and calcific uremic arteriolopathy. The clinical features. Livedo reticularis most commonly occur on leg, but arm and trunk may also be affected. Cold exacerbates this condition, and the cyanotic discoloration becomes more pronounced, while leg elevation tend to decrease the intensity of the color changes. Diffuse arterial disease or hyperviscosity problems give rise to diffuse livedo reticularis. Limited arterial disease lead to patchy mottling. So in many cases, livedo reticularis forms a complete network, while in case of limited vascular occlusion, there is a branching configuration which is known as the livedo racemosa, which is seen in this picture and in this drawing. So if there is a diffuse arterial involvement, it will be livedo reticularis, or partial involvement will result in livedo racemosa. Ulceration of dark areas occur rarely, but if present suggests significant large vessel vasculitis or intraluminal thrombosis. The appearance of livedo reticularis is initially reversible if underlying cause is treated, but with chronic problems, permanent telangiectasias develop. Now, few clinical variants. This physiological livedo reticularis is also known as cutis marmorata. This is a transient cyanotic mottling of the skin that occurs as a physiological response to cold exposure and disappears with warming. It is usually encountered in healthy infants and resolves during the first year of life. Involvement of trunk as well as limb is common. Then congenital livedo reticularis is cutis marmorata telangiectasia congenita, a rare developmental defect present at birth, evident as cutis marmorata, telangiectasias, and phlebectasias. Lesions are usually asymmetrical, typically on a limb, less often torso or head. And it is associated with variety of other congenital abnormalities. Acquired idiopathic livedo reticularis occur in young adults and middle-aged women. Mild degree are harmless, while severe cases are associated with ulcers and usually occur in winters. Tingling and numbness of skin and edema may be present. Differential diagnoses include erythema ab igne, capillary nevi, and angioma serpiginosum. Prognosis is related to underlying cause, and if one is present, then it should be treated accordingly. Typical investigation would include a thrombophilia screening, autoimmune screening, full blood count, metabolic panel, and serum protein electrophoresis. Management is directed to underlying condition when it is identified. So the topic now is cryoglobulinemia. This cryoglobulinemia refers to the presence of immunoglobulin complexes that precipitate in vitro when cooled below body temperature. Cutaneous features in cryoglobulinemia occur as a consequence of intravascular precipitation of these cryoglobulins in small vessels of skin or as immune complex disease. In the demonstration of cryoglobulins, venous blood is drawn into a warm syringe and allowed to clot at 37 degrees centigrade. The serum or plasma is cooled to 4 to 5 degrees centigrade and any precipitate noted. This precipitate should redissolve on warming. Less than 25 milligram per deciliter of cryoglobulin may rarely be associated with symptoms. So for symptoms, it has to be level higher than 25 milligram per deciliter. The mean age of onset of mixed cryoglobulinemia is about 53 years. Pathophysiology. There are three different kinds of cryoglobulinemia. Type 1 cryoglobulinemia is a single monoclonal immunoglobulin, usually IgM, but less often IgA and IgG. It is associated usually with hematological disorders like multiple myelomas, macroglobuliniemias, and lymphoma. These precipitate in blood vessel leading to ischemia from vascular occlusion. Type 2 is mixed cryoglobulinemia with a monoclonal rheumatic factor IgG or IgM. And type 3 is mixed cryoglobulinemia with polyclonal rheumatic factor IgM, IgG, and IgA. Type 3 is most commonly seen with hepatitis C infection, while hepatitis B, HIV, autoimmune disease like Sjogren, SLE, and rheumatoid arthritis are also associated. Clinical features of type 1 cryoglobulinemia. There is acrocyanosis, blue toe syndrome, retinal hemorrhages, severe Raynaud's phenomena, arterial thrombosis, and ultimately gangrene. The features of type 2 and type 3 cryoglobulinemia include arthralgia and arthritis in proximal interphalangeal and metacarpophalangeal joints of finger, hands, and toe, and also in the knee and ankle. There may be fatigue, myalgias, renal, immune complex disease, cutaneous vasculitis, and peripheral neuropathy manifests as numbness on hands and feet. Investigation. Immunoglobulin titer and plasma protein electrophoresis should be ordered. Hepatitis B and C serology should be ordered. Serology for other autoimmune diseases should be sent. Rheumatoid factor titer and C3 and C4 levels should be ordered, which are low. Histology will show the leukocytoclastic vasculitis of small blood vessels. And in cryoglobulinemia without vasculitis, there will be homogeneous eosinophilic material deposited within the blood vessels. Management. Starting drug is NSAID for arthralgia and fatigue. Then we add immunosuppressives like corticosteroid, cyclophosphamide, azathioprine. when there is organ involvement such as vasculitis, renal disease, progressive neurological symptoms, and severe disabling skin condition. Plasmapheresis is used for severe and life-threatening condition. Antiviral therapy is effective in hepatitis C virus-associated cryoglobulinemia. Then anti-CD20 monoclonal antibody rituximab has been reported to be effective in vasculitis associated with type 2 mixed cryoglobulinemia and type 3 hepatitis C associated cryoglobulinemia. We have now covered the diseases due to cold injury. Now we will briefly discuss a few diseases due to heat and infrared radiation. The physical and biochemical effects of infrared radiation comprise approximately 40% of solar irradiation have been relatively neglected. The infrared is the segment of electromagnetic spectrum that extends from the red visible light and microwaves to the microwaves and radio waves. This wavelength ranges from 0.75 micrometer to 100 micrometer, that is 750 nanometer to 100,000 nanometer. There is an arbitrary division of near infrared, middle infrared, and far infrared. The near infrared is 0.75 micrometer to 3 micrometer. Middle infrared is from 3 to 30 micrometer, and far infrared is 30 to 100 micrometer. This energy is inversely proportional to wavelength. Therefore, most biological effects are seen at a shorter wavelength. Most obvious effect is the increase in temperature, and the transmitted infrared radiations can penetrate up to 30 millimeter. Major source of infrared radiation is sun and infrared lamps, but in clinical practice, various forms of radiant heater in the room and workplace, hot water bottle, heating pads, etc. are all important. The acute effect of infrared damage include erythema, which disappear by 6 hours. Epidermal proliferation is reduced by infrared and does not become normal after 7 days. Prior heating with infrared radiation reduces the phototoxic response to methylpsoralen and UVA. The chronic effects, as with clinical solar elastosis, there is also increase in ground substance. Then chronic effect include carcinogenesis. Infrared radiation coagulate protein and nucleic acid and is synergistic with UV radiation in denaturing the DNA. So the DNA repair after UV and X-ray induced damage is slower at higher temperature than at 37 degree. So the infrared radiation increases the carcinogenic effects of UV radiation. Heat, wind, humidity is shown to enhance the UV carcinogenesis. Erythema abignea. It is a characteristic reticular telangiectatic and pigmented dermatosis that results from repeated and prolonged exposure to infrared radiation insufficient to produce a burn. So the first thing is there is a prolonged infrared radiation exposure, but to intensity below a burning intensity. It is seen among elderly people who sit and stand close to fire or heater or habituated by use of hot water bottles. It is also a valuable sign of hypothyroidism. Erythema abignea most commonly affect legs of women, but condition occur at all ages, including in children. This is found on thighs of laptop computer users, seen in abdomen in patient of chronic pancreatitis because local heaters are used to relieve pain in abdomen. In mentally disturbed patients with thrombophilia, bizarre areas of erythema abigne are encountered. Clinical features. Following a single exposure to subthreshold intensity, a mild transient reticular erythema occurs. But on repeated exposure, marked erythema is noticed. Subepidermal blistering is seen. Involution gradually becomes less complete, and changes caused by repeated and prolonged exposure resemble poikiloderma with reticulate telangiectasia, atrophy, melanosis, and diffuse hyperkeratosis. In severely affected individuals, the reticular pattern is lost and a wide area of skin becomes pigmented and atrophic, with only the periphery showing this characteristic pattern. Rarely, lichen planus psoriasis and chilblain lupus may appear as a commoner phenomena on the affected area. Milder cases of erythema abigne settle spontaneously. However, severe cases, pigmentation and atrophy persist despite of any treatment. Management. First of all, removing the heat source from the skin and investigating for underlying cause of pain where appropriate. Hypothyroidism should be excluded. In elderly women living alone, erythema abigne is a sign of hypothermia, and help of ancillary social services is required. Abnormal pigment persists for years. Treatment with topical retinoids and laser help in some cases. The last topic is heat-associated carcinomas. Squamous cell carcinoma of skin occur in areas of heat damage is known since ancient time. And the examples include the Kan cancer of northern China and Japan from sleeping on beds of hot bricks, the Kangdi cancer of Kashmir from wearing pots of hot coals, and the Cairo cancer of Japan caused by carrying metallic benzene burning. The turf cancer of legs of rural Irish women is associated with standing for a long period of time over the peat fires. Then Merkel cell carcinoma with squamous cell carcinoma is the next common cause of heat-induced carcinoma. This brings me to the end of this talk. I know it was a long lecture, and I really thank you for your patient listening. Thank you and have a good day, and see you soon with next lecture of mine.